I would like now to announce the next speaker. It's Dr. Georgina Gethin. She is a co-author of this document, and she will talk about what is best practice in home care, wound care. Georgina.
Thank you very much. Good morning. You the pointer? Good morning. It's great to see you all. My talk follows on very well from Sebastian's presentation, because I'm going to look at what is best practice in home care, wound care, but focusing really on what we understand by best practice. As a starting point, though, I think it's very important that we maybe revisit who it is we're talking about when we talk about delivering wound care in the home care setting. And while our patients can go from newborn infants right through to the very older adult, we're primarily dealing with older persons. And essentially, what we have to start to consider is the whole area of chronic disease management, and the chronic disease perspective, because this is completely linked with our patients with chronic wounds. Patients with chronic wounds will always have at least one underlying comorbidity. So what has been changing? Well, essentially, what we're starting to see is that really from the beginning of the 20th century, life expectancy, if we look in the USA, has been extended by about 30 years, which is quite remarkable. But most of that health gain, about 75% of it, is due to public health interventions, not actually due to clinical interventions. So even things like supply of clean water and electricity, that's having huge impacts on health. And also we've got increased life expectancy with major chronic illness morbidity. And what we've got now is what's called compression of morbidity. So we have people living longer, which is wonderful, but in the later years of their lives, they've got more and more chronic illness problems. So we're getting it compressed into one end of the life spectrum. And this is bringing with it many challenges for us. And just to give you an example from Ireland, about 28% of people are expected to have high blood pressure, which is up about 40% in just a few years. In Northern Ireland, 31% of people are expected to have high blood pressure. Diabetes has increased by 62% to 5.9% of the population, and seeing the same in Northern Ireland. We use the comparison between Northern Ireland and the Republic because we've two different health systems. It's an interesting comparison. But what we do see, and we see it over and over again, is that lower socioeconomic groups have more and more chronic disease. And we see that even in a recent review in the United Kingdom looking at leg ulceration, where the lower the socioeconomic group, the higher the prevalence of pressure ulcers, or of leg ulcers, but also the higher number of recurrent leg ulcers. Other areas that we see, and we looked at this yesterday in one of the sessions looking at obesity, and 61% of adults and a quarter of 3-year-olds are now either overweight or obese. And this has huge implications for us as healthcare providers. And 1 in 4 adults will also experience mental health problems in their lifetime. About 1 million smoke. 12% of children from 12 to 17 years of age smoke. And alcohol consumption is quite high, and in Ireland it's the 4th highest in Europe. And what Barondess would call is that when we talk about chronic disease, we look at a life perspective of chronic disease rather than just in the older adult, and that this should be from conception onwards. And then in terms of cost, well, we know that this is an area it's getting more and more expensive in terms of managing the diseases themselves, but also the medications that are required, and then the support network that is also required to support this. And what's interesting is that, and this is throughout most Western healthcare systems, that health is actually the 2nd highest component of public expenditure after social protection. But if we look at the group of people in terms of lower socioeconomic status, they're the ones in receipt of social protection. So we have a group of patients who are in receipt or for whom the highest part of our budgets are allocated to them. And then we've got our spending in terms of diagnostics and treatment, in terms of obesity, alcohol, mental health and tobacco, and all of these are escalating. So how is this linked with wound care? We cannot really talk about wound care when we're talking about chronic wounds without having reflected on chronic illness. And we need to integrate these conversations more and more, because 3/4 approximately of people with wounds have 3 or more comorbid morbid conditions. So that's a huge challenge in terms of managing this patient population. And when we talk about wound healing and trying to promote wound healing, we have to be cognizant of the comorbid conditions within our patients. And of the frequent comorbid conditions with hypertension, vascular disease and arthritis. And just one example, and this was an assessment done of patients over 65 years seen by one community nursing service, and that included home care. And this, I suppose, further compounds the challenges of managing this group, and that 55% of people were at a risk of frailty. Now, frailty is an index in itself, because the higher your points on the frailty index, the more likely you are to die within 2 years. So it's not a transient term, as in somebody is frail for a period of time, but frailty as an indicator. And of this group of people, 16% were at risk for some cognitive impairment, 20% were at risk for poor nutrition, 30% were at risk of falls, and the dependency with associated frailty was 23%. So how is all of this linked to home care? Well, within the document, what we say is that the delivery of the highest quality, evidence-informed best practice that promotes improved patient outcomes at an economically viable cost to the healthcare provider is the goal of all health professionals and healthcare institutions. But that's quite a statement, and that's quite a big ask. So how do we start to integrate all of this? So what then is evidence-based medicine or evidence-based practice? And this is an interesting concept, and it's been around for quite a while, and it says that evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. And what's interesting in this is that everybody tends to look at the research part of it, that evidence-based practice is research-based practice. And that is true, but that's only part of it. Because what may be best practice where I am may not be best practice in another country. And that may be due to the resource issues, it may be due to the education issues around the staffing, it may be due to costs, and so on. But evidence-based practice takes into account the patient values, and it takes into account the patient's preferences, and it also takes into account the clinical circumstance. So I think we need to refocus on this as a definition if we keep using this definition. So there are 6 steps in evidence-based practice. One is to ask a focused question. So that question may be, what is the best practice to diagnose a venous ulcer? What is the best practice to manage a venous ulcer? So the question would not be, what's best practice in venous ulcer management? We need to ask very specific questions, and then we can try and achieve an answer. We assess the evidence to answer this question. We appraise the evidence for its validity, its effect size, and its precision. And then we start to bring the evidence together with the patient, the healthcare policy, and make a decision. So what is the evidence actually telling us? We then apply our decision, and the final part is to audit the practice and check how we are measuring up against this particular statement or this evidence that we have. And we've seen within the chronic care model, and Sebastian outlined it, was how we use guidelines to support evidence-based practice. And guidelines are they're so important, but again, they're so huge of an issue. And they are, according to the New Zealand Guideline Group, they are systematically developed statements to assist the practitioner and the consumer decisions about appropriate health or disability care for specific circumstances, taking into account evidence for effectiveness, competing claims, and form a fundamental basis for planning. So again, we've got this big, huge definition of, we have to break it down. But essentially what the guidelines are is that they are to assist. So they assist in the clinical decision-making process. They are not prescriptive. And therefore the aim is to guide decision and criteria regarding diagnosis, management and treatment in specific areas of healthcare. So how do they differ from other statements? And they differ from policy recommendations or standards of care. So for example, a policy defines an outcome while a procedure defines the means to an end. So the policy in this healthcare institution is that all patients will have a comprehensive assessment completed by X person. That's a policy. It's not movable, and you adhere to the policy or you don't. A recommendation is put forward with approval as being suitable for a purpose. For example, it can advise on a course of action, make an appeal, make something desirable. For example, a hospital had much to recommend it, or we recommend that all our patients maybe see a dietitian or whatever it is. So it's a recommendation. And a standard of care then is something that's probably at the highest level, in that a standard, it stands the test of time, and it's embraced by multiple diverse groups interested in the care delivered to patients with chronic wounds. So for example, compression therapy is now seen as a standard of care in leg ulcer management. So if I was assessing a case, for example, and a person did not have compression therapy when it was available, I would say they did not meet what was an expected standard in this particular case. So guideline development, it's something that we cannot take lightly, and it involves a very rigorous approach. It involves teams representing various stakeholders and perspectives, and they systematically locate and appraise research evidence to produce explicit evidence-based guidelines. We've just finished some work developing guidelines for the management of fungating wounds, and that's been a huge process in terms of looking at the evidence to support some of those statements that are within those guidelines. And if we go, just in terms of guidelines, within wound care, we've got a lot of guidelines on leg ulcer management, and one of the areas that EWMA is looking at is to try and sort of bring together what are all of these guidelines saying? Are there areas of commonality within them? And this is a project that will be ongoing. But we have, for example, the NICE guidelines, we have RCN guidelines, we have guidelines from the American associations, from the Australian associations, and so on. But there must be certain areas of commonality between them. But why do we keep needing them? And one of the things to support why we might need them is, this was just published in the December 2013, and it was Chronic Venous Ulcers, a comparative effectiveness review of treatment modalities. And this was done by the Agency for Healthcare Research and Quality in the United States. And they reviewed 60 studies in venous leg ulcers. And what they concluded was, we could not draw definitive conclusions regarding the effectiveness of advanced wound dressings in terms of intermediate and other final outcomes, including quality of life and pain measures. This is a huge document and a very comprehensive review. So it's saying to us, look, here we are, the end of 2013, 2014, and all that we've done, and we still can't make definitive statements. So we need almost to reassess where we're at, and this is where the issue of guideline development is so important. So best practice then, it is context related. So if I was, for example, in a developing country, what might be best practice and achievable for me there is not what I might expect at home. It's dependent, therefore, on the organisation of care structures. It's dependent on local resources, the availability of expertise, the education and training of healthcare professionals, and the patient understanding and treatment goals. And in the home care document, we've looked at, for example, recommendations around many of these, particularly around education and training of healthcare professionals. But what about the uptake of evidence-based medicine and of best practice? It's always dependent on the effort to learn and the effort to use, balanced by the perceived value of it or the benefit of it. So if you look at, for example, pressure ulcer prevention, do I have to learn something new in order to implement a guideline or best practice statement? How much training and education will this require? What are the benefits of it? So in terms of uptake of any guidelines or any innovations, this work was done by Rogers, and I think this dates back to the 1960s, and it looked at diffusion of innovation. So how do things actually spread out? And he takes into account 6 different areas, and he looks at the relative benefit of anything. So what's in it for me? How complex it is? Is it easy to learn? Can I try it out? Can I see if this will work for me first? Can I see others doing it? Will it fit in with my ideas and my work? And can I adapt it to me? And the last one there, the reinvention, one of the issues, particularly around guidelines, is that the vast majority of guidelines are related to clinic settings, whether they're at a community or hospital level. But the guidelines, really, we need to look at how can we adapt what we have to the home care setting. Because straight away, if I'm in a clinic setting, I may have colleagues present, I may have other support network present, which I may or may not call on, whereas in the home care setting, I don't have that. But a key issue with regards to guidelines, and it's something that is more often than not overlooked, and if we look at many guidelines and we look at dissemination, it may be mentioned once, it may get a paragraph, but oftentimes it's overlooked, and it's a huge area. And in terms of dissemination, we have to look at who are the target group with actual guidelines, who will actually implement them. Then to consider what communication networks are in place, how will you tell people that these exist, what formats are they available in, what supports are available for them, are there key people or local champions to actually help in the dissemination of them, and are the benefits of it clearly identified? And some of the barriers that have been identified for effective dissemination centre around knowledge and attitudes and behaviour of people. Some of the strategies in terms of dissemination have also been looked at, and what's key with all of these is that it takes more than one approach. So if you want to effectively, so even in terms of the home care, wound care document, we want to disseminate that. How are we going to do it? We're not just going to take one approach, we're going to take multiple approaches. So it's been disseminated through the Journal of Wound Care, it's been disseminated through online email shots, it's disseminated through the conference, it'll be disseminated through publication. So we're not dependent on any one particular mechanism. And what it's saying with dissemination is we need to use a variety of mechanisms. And in terms of implementing them, and this is put forward as a recommendation, how you may start to structure looking at implementing guidelines, or even something like this document within your own area, to look at where it's to be implemented, what is the aim of it, who do we need to inform, who do we need to have on board, and how are we actually going to do it. And these then, when we try to fill this in, we do it at the national level, the local level, the practice level, and at the individual level. And non-application then of such guidelines may be due to many issues. It could be due to lack of awareness or agreement with them. So people need to know who was on the team that developed these guidelines. How credible are they? How well do I support their work? Some of the other reasons for non-application may be because there's a lack of outcome expectation, or there may be other barriers. So the work area may not actually support implementation of these guidelines. So in terms of our 6 steps of evidence-based practice, the final step we said was audit, and this is one that we have to constantly look at. We've determined what best practice is through our steps 1 to 4. Then for each of us, we need to survey, see how we compare with such best practice. Is there a gap? We need to consider, are there reasons for a gap? And then try and do further implementation, re-evaluate, resurvey, and see if there's any improvement. And just to finally, I suppose, bring some of it together, the very interesting paper done by CAP and colleagues, and they looked at patients with pressure ulcers in the home care. And I felt, you know, while there's quite a bit of literature, but this encapsulated things very well. And she interviewed 7 clients, all who had pressure ulcers and were being managed in their own home. And 4 themes emerged out of this analysis, which were consistent with some other work in the area. And people described trying to live with the discomfort of having a wound, the constant pain, the constant soreness, the fear of dressings because of the soreness, the fear of movement, the fear of appliances because of soreness. And people had to cope with that. But an interesting thing that was identified was to live with differing interests. And what people described was that so many different professionals were coming into their home, so coming into their space, but each one had a different focus. So the occupational therapist came in to look at, for example, mobility, the physiotherapist came in to look at something else, the nurse may have come in to look at the wound, but each one was not interested in what the other one was doing. And it also meant there were different sets of records for the patient within this one home. And the patients themselves described that they were having things done to them instead of things done for them. And you know, even the EWMA document on managing wounds as a team has identified we need to start to build this team approach, but the patients themselves could see that there was no team approach. They also described living with restrictions, and those restrictions were imposed by the wound, but there were also restrictions because they had to constantly wait for health professionals to come and visit. And also patients described that they had to place trust and have faith in the nurses and others that were delivering their care. And they have some recommendations at the end, which I think, as I say, kind of synopsize where we're at. And they recommended that home nurses are attuned, or they're mindful of the potential negative impact of pressure ulcers on the ability of older people to live at home, and to try and intervene early to protect it. Because living at home is very, very important. Also recommends that education for home nurses includes not only prevention and management, but also provide care that improves health and well-being. And that further research to produce best practice for this care setting is needed. And I think this is probably where we need to start to look at putting our efforts. How can we implement best practice within the home setting? So in summary, we've got a changing profile of people being treated in their own homes, much more complex caseload. We've got an increase in the numbers of people being treated in their own homes. We need to develop guidelines and evidence-based practice tools suited for the home care setting. And we need to support and develop multidisciplinary team working. Thank you very much.